Hello, everyone. My name is Gabriel Altit. I'm a neonatologist at the Children's Hospital, and today I'll be speaking about how I manage a preterm baby with low blood pressure. And it is my pleasure to present this for the upcoming annual International Neonatal Conference for the James Cook University Hospital conference. And so um, I do want to mention that the current presentation is based on my own experience and my own interpretation of the literature, some of which I participated in. Most medications discussed have not been tested in the context of RCTs targeting newborn. And I do want to mention that Mallinckrodt supported the NeoCardio Lab through an unrestricted education grant. So I'm hopeful that by the end of the session, the participants will be able to describe the physiological concepts underlying perfusion and shock in the preterm infants, and that we will be able to recognize some phenotypes that may be explaining shocks in prematurity. And I did put here a QR code that would bring you to a section of my website where I actually shared some of the local protocol that we use for the hemodynamics of premature infants, especially during the transitional period. So very quickly, because we will be looking at some of the basic views of TNEs, there's many elements we check by targeted neonatal echo, but here this is a standard view of a parasternal long axis view. So you see here the left ventricle, the mitral valve, the left atrium, the aorta, the LV outflow tract, and very quickly we can see that there's a nice squeeze to this left ventricle. The walls are not kissing, so it seems that the preload is adequate. And we can see that the outflow tract is opening and closing. This is the short axis view, which is the 90-degree from the previous view or a view from on top, where we can see here the level of the mitral valve and here the level of the mid-papillary muscle of the left ventricle. Here we see a nice round left ventricle at the peak of contraction compared to a very slim crescentic RV, telling us the relationship between the LV and RV systolic pressure, with the LV systolic pressure likely being higher than the RV systolic pressure. It also provides us with some information on circumferential contraction and wall thickness or hypertrophy. And this is an apical view where we get the relationship between the RA, LA, RV, and the LV. We get to see that the RV, which is a longitudinally contractile organ, has really good contraction with this tricuspid valve going up and down nicely. And we can appreciate the LV cavity and get a sense of function and filling as well within this particular view. The subcostal view informs you on the interatrial relationship. And so here in most babies, you do get a shunt either via foraminal valley or atrial septal defect. And so here it's left to right because red means it's coming towards the probe, and this is the right atrium, left atrium. So you have left to right shunt at the interatrial level, which is very normal in many of the babies. And it informs us on the preload of the atriums, the relationship between them, and also some information about the end diastolic pressure in each ventricles relative to each other. Because if the RV and diastolic pressure rises, then the RA pressure will rise during tricuspid valve opening. And if it's higher than the one on the left compartment, you'll get a component right to left shunting. In the suprasternal view, you get information either of the arch, or you can do a modified view and get what we call the ductal view. So this is a ductus arteriosus, and here it's red, so coming towards the probe, so bringing blood flow from the descending aorta towards the pulmonary artery. And so it's left to right. And so it informs you about the relationship between the pulmonary and systemic compartment relative to either pressure or resistances, depending on how big this duct is. So I'll start with a case, which is a case very benign of a 25-week-old baby girl who was born in the context of maternal preeclampsia with no infectious risk factors. There was no history of volume loss, and at 24 hours of life, this baby has had an uneventful first 24 hours, being on CPAP with a bit of oxygen and occasional events. There's a gas that is very reassuring with normal lactate. The hemoglobin is normal, and there's a first head ultrasound that was done that was actually normal in this patient. The urine output is appropriate. The baby's well perfused on exam, active in pig, with a heart rate appropriate for age. But you're called at bedside because the blood pressure read on the umbilical arterial line has been dropping, and you have now 27 on 17 with a mean of 19. And so I've put here the populational-based blood pressure values that we use locally in our unit, which is something that's been standardized across Canada through the EPIC Collaborative. And you can see here, and it is referenced a bit later, as well as on the website in the QR code I provided. But here, what we see is basically the fifth percentile for the mean. And at 25 weeks, we're supposed to be 20, and so we have 19, so it's a bit low. So I've asked the Twittersphere or the X sphere, and that's non-scientific, but I've asked in a little survey, what would you do with this particular patient that I just described? And you can see that actually the majority of patients would get either an echo for more information on the physiology, or would actually ignore it completely. Some of which answered they would give inotropes or vasopressor or even a fluid bolus. But I think the vast majority would want to get a bit more information or actually just either ignore or follow the clinical status. I changed a bit the vignette and I've asked, now that you have this patient, but it's actually showing some signs of gray, clamped, cold, with a long refill, what would you do? And the majority actually would say either to start medication or actually get an echo for more information, which I find was interesting. In our unit, we would definitely get an echo to get more information, but that depends, I guess, on how readily it's available, who's able to perform it, interpret it, and provide the physiological information. And I think if you have a patient that's showcasing sign of an organ hypoperfusion, you want to act upon it before you get an organ injury. So in our unit, we would get a TNE. I've put 3 very classic view, the parasternal long, short, and apical 4-chamber view. And here we can appreciate there's relatively good filling, good ventricular function, appropriate relationship between the RV and the LV. We can see the RV function looks relatively well. All of these are very subjective at this point, but in our unit, we would also do some of the metrics to quantify these things. But I think you can appreciate that this cardiac function looks within normal limit. And so our particular approach for this baby would be to really monitor clinically and transit status, and we would not intervene at this point, but we would obviously make sure that there's no changes through time in this particular baby. So before we address like the whole concepts of hypotension and what to do with it, I told myself, well, let's go back a bit to the physiology. I think what we all try to prevent is tissue injury or a state of shock in these patients. And what is shock is really the tissues not receiving adequate supply of oxygen and nutrients to meet the demand. And because of that, it leads to tissue ischemia, dysfunction, and necrosis. And what we want to maintain is this matching between oxygen, nutrient delivery, and metabolic demand without creating situation of hyperperfusion, which can actually make damage, or hyperoxia, which we know is also not something great for our preterm infants that are quite vulnerable. So we always want to maintain this kind of tight balance with the interventions that we do. And, first thing, you don't want to hurt. And sometimes we have a tendency to be very proactive in some of these babies. And I think sometimes to just let them transition is also an important element, obviously without being neglectful or ignoring them, but really by balancing the needs for intervention versus what's actually the goal of those interventions. So I think when we look at our preterm infants, we can, look at some of these trends that are very important. So obviously blood pressure, heart rate, vital signs. We know that blood pressure on its own, the number itself doesn't tell you much. And the reason is that the blood pressure reflects the relationship between the resistance within a system and the flow within the system. And so you can maintain your pressure even if there's very low flow if you start increasing resistance by compensatory mechanism and vice versa. So sometimes we do have to look at trends and trying to understand what's happening in the systolic upstroke, which reflects often the systolic contraction, what's happening in diastole, which is the residual pressure in the system. Either is there a steal or is there a vasodilatation that is within abnormal limit? What's the mean? We'll talk a bit more about that. Are there differences in my different kind of limbs, and where am I how am I taking this blood pressure? Where am I taking this blood pressure? And obviously, I think that trends in general are more important than absolute numbers, and they need to be put into context into the whole clinical presentation. We also look at heart rate as signs of concern. We obviously know that our preterm infants have autonomic nervous system immaturity and sometimes even anomaly if they're infected or with chorio. There's capillary refill time, which is important, but can be also subjective. And so if you see a warm shock, you have to think of low systemic vascular resistance. You have to think also where's the location where you're picking up this capillary refill. The pulses and physical exam and the liver edge can provide you with information on perfusion. And obviously, a baby that's very cold to touch and model, you have to think about high SVR. And so you can have babies with a normal blood pressure who are completely in cold shock because they're actually compensating. Babies with abnormal body temperature or you need to actually rewarm them a lot when they were actually having not that much demand from the incubator previously. And if you find hepatomegaly on exam, you should think about signs of high RV and diastolic pressure, or that could also be secondary sometimes to high mean pressure on the ventilator. We all know that babies who have changes or alterations in their level of activity or consciousness, which can be difficult in extreme preterm, but these babies that were vigorous and suddenly very limp, or having suddenly a lot of apneas and rades, are of great concern. Urine output is sometimes a good indicator of renal perfusion, but it's often a late indicator. It's also influenced by many other factors, such as fluid status, and acute kidney injury and renal immaturity. Lactate is a marker to get a sense about, as well as acidosis or pH. But sometimes you can have changes that are related to sampling or growth restriction, placental insufficiency, where you get buildup of lactate in tissue prenatally, or there could be other cause of increased lactate, such as high metabolic demand and seizures. And so it's important to keep in mind to use a constellation of markers, but all of these markers on their own may not be sufficient to classify a patient into a particular pattern of normal or abnormal. And so that's why I think sometimes having an echo provides you with a bit more of that physiological information in the context of all of this. So I did mention that pressure is a function of flow and times resistance. And so if we put it into the context of the overall system, we can think about the blood pressure as cardiac output times resistance. We know we are a pulsatile pressure system with a systolic and diastolic phase. And so the mean is actually the area under the curve of these pressure curve. And so the systolic can be influenced by the cardiac ejection, the preload, the Frank-Starling curve. The diastolic is typically what's residual in the system and will be influenced if there's a steal somewhere or if there's a very high compliance or low resistance system, such as if the SVR are dropping. We also have to remember that we get a blood pressure in both the pulmonary system and the systemic compartment as well. And in the preemies, we have, the added challenge that there are shunts like PDAs that will connect these two systems together and may influence the dynamic between the two compartments. So if we look specifically at the cardiac output, and these concepts are applicable to both the RV and the LV, well, cardiac output is typically dependent on stroke volume and heart rate. We know that stroke volume is dependent on contractility, preload, and afterload, and there's many reasons why stroke volume could be affected in preterms. Example, contractility, we know they have myocardial immaturity, they have smaller capacitance, they can be exposed to stressors like chorio or asphyxia or certain medications that may affect contractility. Preload of the LV is both impacted by the interatrial shunts as well as the lung perfusion, but also related for clamping, intravascular filling, bleeding events. And we know that there are a lot of cardiorespiratory interactions that can affect preload. And they're particularly more sensitive to tachycardia because it decreases filling time. And finally, afterload also will change depending on cardiorespiratory interaction and connections by shunts. The heart rate on its own may obviously be a compensatory mechanism, but there's a maximal to which you can compensate. Eventually, you'll start decreasing your filling time. And so there are many things like autonomic nervous system maturity, some of the medication we use, and some of the hormonal control or maturity that will affect heart rate. When we look at resistance, we often think about total peripheral resistance as the sum of all those regional resistances. But there's a lot about autoregulation and specific organ autoregulation that we don't know about. And specifically, for example, at the brain level or the kidney level, and whether with increasing immaturity or disease status, these autoregulatory mechanisms may change. So inflammation, autonomic nervous system, some of the hormonal or steroid control can change that. And some of the medication we use will also affect these autoregulation mechanisms. So think about a baby with a meningitis or seizures, exposed to certain medications may also impact how these vessels are behaving. And we rarely talk about viscosity, but it does have a small role to play in the resistance profile. And then finally, we know that these babies undergo a transitional physiology. And so, especially in those that did not get delayed cord clamping, they may be more susceptible to shifts of blood pressure because of these changes in both the stroke volume and the resistances in the transitional period, and especially when they have connection between the two compartments. So I think many of you are aware of the recent publication of the HIT trial, which was meant to try to solve to some degree the dilemma we face when we see dropping numbers of blood pressure in babies who are otherwise quote unquote well. The investigator of the HIT trial had done some preliminary work and found that actually half of the babies who were born extremely preterm at the time in unit that were surveyed were receiving interventions for low BP, whether it is a bolus or at least up to a third were receiving inotropes. And so we know that dopamine will increase blood pressure, but we have no idea if this will affect short or long-term outcomes. And actually, some of these medication may impact the perfusion at the level of the brain, or even the vasoconstriction at the brain, or even create status of hyperperfusion, which can lead to more risk of IVH. And so, based on these findings, a lot of it coming from observation, but also some from RCTs, there's been kind of a push to be a bit more thoughtful about having a more restrictive approach towards inotropes when these patients are not showcasing either physical exam signs of low perfusion, as well as with complementation with other modalities, such as, for example, targeted neonatal echo that provides more of the cardiac functional information. So if you look at the result of this trial, unfortunately was terminated very early with 8% of the planned recruitment. And they found no difference in survival without brain injury. And even on the long term, there was not much survival, but they were never able to reach the planned recruitment rate between the placebo and the dopamine groups that were kind of enrolled for a low blood pressure, which was considered below gestational age. And so what is exactly hypotension? It's, what we would call a low or tension blood pressure. But as I said, it doesn't mean necessarily low flow. And then premature will often have dropping numbers as the PVR will drop and the PD is still open just because of the relationship between the two compartments and some degree of the Steele effect. And more often you'll see this diastolic blood pressure fall with a bit of this systolic upstroke and some degree of this mean blood pressure that starts decreasing too. We know that inotropes and vasopressors have side effects and toxicity. And, I tend to be of the philosophy that less is often better without being necessarily neglecting these babies. And so it's important to recognize the necessary situations to support the cardiovascular system. Why is it important to support the cardiovascular system in some of these patients that have pathological situation is that we want to avoid being in a situation where you have a pressure passive brain circulation. And we know the cerebral autoregulation can be affected by prematurity and some of these other things which I've mentioned prior. So for those who don't know, there's this wonderful book by Dr. Rudolph, which talks a lot about cardiovascular physiology and really provides us great insight with some of the studies that have been done in the lamb models and animal models of fetal life and postnatal transition. And so when I went back about, what is this idea of hypotension and prematurity? Dr. Rudolph mentioned it was suggested that the level of BP can be considered to be normal if equal to the gestational age in weeks. And he actually outlines this is somewhat arbitrary, and it's completely arbitrary and has not been confirmed by any reliable observation. He also mentions that little information is available. The earlier the gestation, the lower the pressure there will be because of their adaptation. And however, there's no actual standards for pressures to be used. So that's one of the first things we did at the Canadian level is that we reviewed a lot of the literature, we reviewed some of the cohort studies, and there's been normative value that were established with association to some of the adverse outcomes. And these tables are just meant to actually provide red flags at the bedside in order to trigger an evaluation rather than to actually use that to treat or intervene per se with medications. And so I'm provided those that are related to the first 24 hours as well as by corrected post-conceptual age. There are also recent curves that were published in Neonatology. So I'm providing this as a reference. And you can see here that this is by corrected age for systolic, mean, and diastolic pressure, and just provides you kind of like where are we in terms of the fifth percentile as per this particular cohort study. And this is using cuff BP. So there are many different small RCTs that's been done prior to the HIP trial. Many of which I didn't outline here. I did put a few one-liners on some of those that I thought were interesting. But as you can see, these are very tiny study, some with N equal 40, N equal 20 patients. And basically what we know is that many of the medication that we use like DOPA, DOBU, EPI will increase heart rate, will increase BPs, but it's really not clear that in these patients who have dropping numbers and no other signs of hypotension, of hypoperfusion, you'll actually make any big difference in the outcomes of these patients. And actually some of them develop side effects of the medication. And so I think it reinforces the idea that, well, first of all, maybe we need new RCTs that are robust on the topic. But second of all, that acting upon these patients just based on numbers is probably not the right strategy. More than concerning is that there was even a pilot RCT that was not even feasible because they were not able to recruit because of lower eligibility and consent rate. So we have to reflect on how we design these studies and what are the outcomes that we're trying to change. And maybe more physiological information needs to be included in those. So let's talk about management when we're seeing these patients. I think a lot of it are based on physiological assumptions and many of which on observational data, just because the RCTs are not there. I do like this article by Dr. Regan Gissinger, who looks at basically the concern for systemic hypotension in the premature critically ill neonates and divides it based on systolic or diastolic pressures, and then provides you with rationale depending on what we would consider to be different etiologies of concern. And she also provided an approach table. And because you'll have all my slides, you'll be able to go back and see this article in depth. But I'll try to speak a bit more about when I consider it to be an abnormal condition, or at least when I do see signs of hypoperfusion, I try to understand what could be the mechanism that I need to address. So the first thing is obviously when you have cardiac dysfunction, low cardiac output, and a low stroke volume, because there's some degree of cardiogenic shock, either from the RV or the LV side or the biventricular side. And we'll talk a bit more about this tomorrow during some of our case presentations. But when you have cardiogenic shock, especially in the preterm, you have to think about, well, could there be some degree of abnormal transition with high PVR and RV failure? Could there have been some degree of coronary hypoperfusion or hypoxia or asphyxia in some of these babies that had poor tolerance to labor and potentially stressful perinatal period? There could be some degree of other elements that are rarer that you have to keep in mind, like metabolic conditions, congenital heart defects, inflammatory reactions secondary to sepsis or early onset sepsis, or maternal inflammatory conditions. And obviously, if you have signs of arrhythmias or fetal arrhythmias, that could also be a reason why you would get a cardiogenic shock picture. And in patients with any kind of left ventricular outflow tract obstruction. So this is an example of a baby born 30 weeks who obviously had signs of asphyxia on port pH and a really adverse transition. And you can see that compared to the previous echoes that I shown, there's really kind of a standstill of the LV. So it's not surprising that this baby is not able to provide sufficient LV output to match metabolic demand on top of having a great stress during the transition and probably some degree of tissue ischemia that happened even prior to birth. So this is a patient that I would actually obviously consider supporting with medications to improve the cardiac function. But it's not just about the medication. It's obviously about, the cardiorespiratory interaction, making sure the calcium is within normal limit, and trying to decrease the metabolic demand and the cardiogenic demand while working on improving the cardiac output. The second big category is obviously hypovolemia or low preload. This tends to happen less in the era of delayed port clamping, but you still have consideration in which this could happen. Earlier on, there are situations with, events in the perineal period with blood volume loss, like placental event, acute fetal maternal hemorrhages, external or internal hemorrhages like intracranial hemorrhages or pulmonary hemorrhages that could happen earlier on. If you're caring for patients in the emerge, you can have shaken baby syndrome with a lot of brain bleeds. And then there are situations with third spacing like high drops, pleural effusions, lymphatic disorders. If you have some degree of early onset sepsis or eventually later on necrotizing enterocolitis, there are some patients that will just get very dehydrated, like because of urinary loss or because they do have a renal condition or a GI condition. Patients with twin transfusion syndrome are particularly sensitive to preload, especially the receiver, and especially if they have cardiac hypertrophy. And as I mentioned, severe hypertrophy, like example, an infant of diabetic mother, which is less something that we see in prematurity generally, but these patients can be quite preload dependent. And so they have a tendency to have much more kissing ventricles, both on the RV and the LV. They have small atriums. Sometimes we look at the IVC to get a sense, but if these babies are intubated, it's harder to interpret the IVC. And this is just a view where we try to get a sense of what we call the cardiac output. And it's very much diminished because basically the LV is pumping like kind of from an empty chamber. So these patients really, my first step would really be filling. So either because of the history or because of my findings on echo. This is another example of a baby who had a high drops and eventually was restricted in fluid. And you can see this cavity is both hypertrophied and on top of it, you have kissing ventricles from the LV side and even from the RV side. So this patient required a bit more filling. And post-filling, you can see that now you see nicely a cavity both from the LV and the RV. You have bigger left atrium, right atrium, so a bit more juice introduced in these cavities to improve cardiac output. Distributive shock is what we call typically as a loss of systemic vascular tone with severely reduced systemic vascular resistance and maldistribution of flow. Typically, these patients have a hyperdynamic heart, they're tachycardic, and typically they do have potentially a component of preload dependency, but they may have received enough preload, and at this point, the LV is pumping against no resistance, and so there's pooling inside this circulatory failure. And so this can happen often in the context of sepsis, like especially E. coli or gram-neck sepsis or neck, or in any condition that will lead to systemic inflammatory response syndrome. We see that also in context of adrenal insufficiency, thyroid storms, and STSS. And so you can see these patients typically will have some degree of filling after they got preload that's been addressed, but they remain very tachycardic and they typically have very high output, actually like 400, 500 cc per kilo per minute. And then we talk often about obstructive shock, which are situations where you can get impairment in the cardiac output, either because there's a mechanical compression, such as a tamponade or a pneumothorax, or even very, very, very high mean airway pressures. Sometimes you can get like very severe neck, which has extremely high intra-abdominal pressure, which creates compartment syndrome and really diminishes the preload to the cardiac filling. So I've seen that also, or situations that are very rare, like severe pulmonary embolism or severe pulmonary hypertension with critical RV failure. So this is an example of a tamponade. You can see that there's even flopping of the atrial wall. It's typically a restrictive physiology, which means that it's impaired filling. And so really the response is to drain this pocket of fluid that is impairing cardiac output. Or situations where you have severe RV failure because you have a suprasystemic pulmonary hypertension crisis. So the cardiovascular management, when you have situation of hypoperfusion and organ injury, is that you must address the underlying cause to reverse the process, either, for example, by supporting ventilation, oxygenation, and organ function, antibiotics if you think there's an infection, hydrocortisone if you think there's adrenal insufficiency. If you have a cardiogenic shock, obviously, we need to address the primary issue of the cardiac failure. We need often to add some degree of inotropic support to help contractility. Sometimes you need to decrease metabolic demand, such as avoiding hyperthermia, making sure the baby is supported from a respiratory standpoint, and even sometimes we need to keep the baby calm so that the metabolic demand doesn't increase. And very rarely, we do need to potentially consider decreasing active load in certain situations or even keeping the duct open. Hypovolemia is typically volume plus or minus antibiotics if you think there's an antibiotic component to the context. Distributive shock is obviously maximizing preload and consider vasopressors that will increase your SVR. And if you have an obstructive, it depends on the etiology. If it's abdominal, you would want to do a drain or a laparotomy, depending on the stability of the patient, or the drainage of the tamponade or the tension pneumo, or decreasing your MAP if possible, if that's causing really impact on your preload and afterload. I've put here a summary of some of the medication that we use to manipulate pulmonary vasodilation constriction, as well as systemic vasodilation constriction. We will review some of these therapies in another talk. And so this is more for your reference. And here I've put a bit more of kind of my own cheat sheet of when I start considering different medications for different etiologies, with a table for those that are more like kind of table reads with impact on heart rate, contractility, SVR, and PVR. I'll finish quickly on mixed pictures of shock and hypoxia. Sometimes we can get full. This is an example of a patient with significant LV dysfunction, a bit of a biventricular dysfunction. Actually, the RV is not doing quite well, but you can see there's a clear left to right PFO with a right to left PDA. So these patients basically have a right to left PDA that is often promoting systemic blood flow. And they have left to right shunt at the atrial level because the LV pressure is high because it faces a high LV and diastolic pressure. And so typically these patients have within normal or near normal preductal SATs. It depends on kind of how the lung parenchyma is doing. And then they have postductal desaturation, but you want to maintain this duct open, and you want to maintain because they kind of are almost hypoplastic left heart physiologies in these patients. So these patients would be treated with inotropic support and not INO. So typically dobutamine and plus or minus maintaining the duct open, and if severe, you would even consider epinephrine. This is a case of biventricular dysfunction. So there's reduced RV function, reduced LV function, which is kind of more pronounced. And in this context, we had low perfusion or low velocity of blood flow in the brain. You can see the RV looks stunned here and barely contracting here, and the LV also has quite difficulty of contraction. And in this context, you get bidirectional shunt at both the atrial and PDA level. And so these patients typically have low output from both ventricles, and these patients are particularly prone to an organ hypoperfusion. And they are typically relatively blue if there's a high fraction of the oxygen of blood entering at both the pre and postductal areas. And so in these contexts, when you have biventricular dysfunction, again, these patients are typically covered with inotropic support. Acute PH can also happen in prematurity. I don't want to go into the controversy about how to manage with INO in these patients, because that could be a talk on its own. But typically, these are patients with high PVR that have a right to left shunt, both the atrial and ductal level. And so they can be quite desaturated in blue. This is an example of right to left at the duct and right to left at the atrial level, introducing the oxygen blend to the systemic circulation. These patients may or may not have a component of cardiac dysfunction. This particular baby, the RV and LV functions were preserved. And so this is more of a classical picture of acute PH. And so obviously optimization of ventilation, INO would be your first line therapies. I did put here the reference from the AP that talks about, that there's no clear evidence that INO improves survivals in preterm infants. And actually, there's no evidence that it supports with INO for preventing BPD IVH, but there's no great studies looking specifically at PPHN in these patients. So that's why for the Canadian CPS's statement, we said that we should consider it if there is some echo evidence of PPHN in these patients, and especially if there's been kind of a concern for hypoplastic lungs. We recently looked at our Canadian data, and we saw that INO in these specific patients with early acute PH that responded to INO had much less mortality. And so based on that, there's obviously a tendency in Canada to at least consider it if we have the PPHN physiology. Finally, in these patients that have a closing duct and severe RV failure due to PPHN, they typically present like this with high RV pressure, TR, a struggling right ventricle. They often have suprasystemic RVs and tiny ducts. And so in these patients, you would want to consider reopening the duct if the RV is severely impaired, and you would want to also support the RV function. So the last case is a case of a baby that's crashing, who was previously well and has a central line access. And you can see that this is secondary to a tamponade. And so in this preterm infants, actually, you're happy that you've narrowed down the physiology because it's not an inotrope or cardiovascular med that will improve this patient, but it's really drainage. This is a subcostal view where you can kind of see the heart floating into the pericardial sac. I've put here, and it's also on the website, kind of indicators of how to perform an emergency TAP in these patients. Not something that I would wish to do at 3 a.m. And this is a real life example of a colleague of mine who provided it after a workshop we've done specifically at trying to recognize these complications. And you can see even the PICC line in the right atrium and the fluid that was tapped in a patient that was decompensating in the first few days of life, secondary to PICC line infiltration. And so you can use also the opportunity of looking, and so that's an example where you would see your PICC line kind of entering, or your UVL entering inside your right atrium using this subcostal sweep. So shock in prematurity remains under study, and I think we have to remember that premature infants are particular in the sense that they have their own transition, adaptation, myocardial maturity, and response to therapies. I hope I convinced you that BP is not just about perfusion, it's about many other elements that we have to look into. BP is just a number, and you have to reflect on clinical findings and hopefully some of the echo findings that can complement this and the story of the patient. And I do think that, in the context of just low numbers, I would actually try to understand if there's a pathological process and use this information to select which approach to take. If there's no signs of pathology, I would just follow this patient. But if you have cardiogenic or distributive shock, there's obviously interventions to do. And then finally, I think that more studies are needed relative to the multimodal evaluation and management to improve meaningful outcomes in these patients. So I want to thank you, and I hope this was useful to your practice.